It's time for me to do another internal medicine QBank video where I try to solve board review questions right in front of you guys. So why don't we just get started? A 45-year-old woman presents to the outpatient clinic with a 3-month history of progressively worsening bilateral hand and wrist pain, stiffness, and swelling. Immediately, I'm kind of thinking some kind of like autoimmune things, potentially rheumatoid. So I'm going to see where this takes us. Laboratory findings follow. ESR is mildly elevated at 35. CRP is pretty elevated at 15. Rheumatoid factor negative, anti-CCP negative. So seems pretty unlikely to be rheumatoid, although you can have seronegative rheumatoid arthritis. Which of the following is the most likely diagnosis? Osteoarthritis, systemic lupus erythematosus, probably not in a 45-year-old woman. Seronegative rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis. So osteoarthritis is also probably not going to be in such a young patient, and really should not cause an elevation in your CRP. Lupus, again, I would expect a younger patient. Joint pains can be how it manifests initially, but a lot of times they're going to give you like a rash on a board exam question. Ankylosing spondylitis, probably going to be more of a back pain type of picture. So let's try and see. She reports the stiffness is worse in the morning and lasts for greater than 1 hour before improving. That's very classic for autoimmune diseases, rheumatoid arthritis, whereas osteoarthritis tends to get worse towards the end of the day. She denies any recent trauma, infections, or travel. Family history is significant for psoriasis in her father. She works as a teacher. She does not smoke and drinks alcohol occasionally, uses ibuprofen as needed for pain relief. Vitals are all normal. And on physical exam, the metacarpophalangeal and proximal interphalangeal joints are tender and swollen bilaterally with a limited range of motion. So MCP is here, and then proximal, so MCP and PIP. There's no involvement of DIP. Now, one of the things that, we've got that family history of psoriasis, but psoriatic arthritis often will involve all three of those joints. So rheumatoid arthritis, think DIP and PIP. Did I say osteoarthritis? Yeah. And then rheumatoid arthritis, it's going to be MCP and PIP. And then psoriatic, all three. Plus, oftentimes on the board exams, they're going to give you like nail changes. They'll give you a history of a rash too. I don't think the rash, the psoriasis in her father is going to be strong enough. I think most likely it's going to be seronegative rheumatoid arthritis, but I can't rule out psoriatic arthritis. So yes, and we are right. 79% of people got this. So let's see how they differentiated between rheumatoid and psoriatic arthritis. The patient does not have a personal history of psoriasis, and the pattern of joint involvement is more consistent with rheumatoid. However, psoriatic arthritis would be considered if the patient had a personal history of psoriasis or other characteristic findings such as dactylitis, nail changes, or asymmetric joint involvement. All right, next question. A 52-year-old woman presents to the primary care clinic for more wrist pain that has been going on for several years. This is probably carpal tunnel, okay? It's one wrist, and I already see that she works at a call center. So let's see. On exam, there's decreased sensation to the first 3 digits. So 1, 2, 3, which I think is ulnar distribution, ulnar nerve, and then median nerve. But either way, a lot of times it's going to be carpal tunnel, right? Or cubital tunnel. Cubital tunnel is interesting. Let's see. Sorry, let me read through this for you guys first. The thenar eminence is smaller on the right wrist than on the left. So basically her thumb is like less innervated. Which of the following is the most appropriate next step in management? So steroid injection can be considered for carpal tunnel, I believe. Carpal bone mobilization, I have no idea what that is. Continuous wrist splinting is not good. If you want to help treat carpal tunnel, you can do like night splinting, but you do not want to continuously splint somebody's wrist because it's going to become immobilized. And so like I see like 3 treatments for carpal tunnel. And then really this distribution is really fitting, I believe, the ulnar nerve distribution. So she works at a call center and the pain affects her ability to perform her job. Applying a wrist brace at night improved the pain. Interesting. Yeah. For some reason, I'm thinking that carpal tunnel involves these fingers more and then ulnar nerve does these more. So maybe it's cubital tunnel, but this may just be carpal tunnel and I'm totally getting it wrong. I'm just forgetting my nerve distribution a little bit. And it is carpal tunnel release syndrome. So I got a pretty easy question wrong because I was already thinking she's already doing a wrist brace. The fact that she did a wrist brace at night that improved the pain, that does make sense. But I'm surprised steroid injection isn't also a potential answer. A steroid injection may improve the symptoms with moderate CTS. However, this patient has severe carpal tunnel syndrome. Cubital tunnel syndrome refers to entrapment of the ulnar nerve at the elbow. Oh, okay. I got them flipped. That's why. Okay. So my mistake, you guys. I got my nerve distributions flipped, and that's why I got this question wrong. I feel like such an idiot for getting this one wrong. And it totally makes sense because, I mean, her symptoms were improving with nocturnal wrist splinting. That's carpal tunnel, right? Right here. So yeah, ulnar nerve is going to be the 4th and 5th digit. And then median nerve is the first 3. God, that's so obvious. So obvious. I can't believe I messed that up. All right, next question, you guys. Let's try and redeem ourselves. A 32-year-old woman presents to the outpatient clinic seeking preconception counseling. She appears healthy, and her lab shows normal PT, normal PTT, normal D-dimer, an ANA of 1 to 80, and 3 antiphospholipid antibodies are all positive. Which of the following is the most likely cause? Factor V Leiden, protein C deficiency, celiac disease, APLA, and lupus. Okay, so she has a history of 2 consecutive first trimester miscarriages, unprovoked DVT, arthritis in her family, and lupus. Okay, this has to be antiphospholipid. I mean, there's nothing saying that it's not. They're not giving us anything that suggests factor V Leiden. I mean, factor V Leiden, I think, is probably one of the most common things that's abnormal. I don't know if it would cause an elevation in like PT or something. But yeah, this lab work and the history is just way too consistent with this. And just so you guys know, the way to diagnose antiphospholipid antibody syndrome is the Sapporo criteria. And so this one was pretty obvious for antiphospholipid antibody syndrome. A 42-year-old man presents to the emergency department with a history of head trauma that occurred a few hours ago. His vital signs show a heart rate of 46, blood pressure 174/92, and respiratory rate of 9 per minute. That's pretty low, and he's unresponsive. Which of the following is the most likely cause of the patient's symptoms? Ischemic stroke, subdural hematoma, subarachnoid hemorrhage, epidural hematoma, and vertebral artery dissection. All right, let me see if I can remember this. But what can cause bradycardia, hypertension, and abnormal respiratory signs? That's the Cushing reflex, which is usually due to increased intracranial pressure, I believe, which would make sense if he had a bleed, right? So running when a branch fell and hit him in the head. Okay, so subdural, very likely because the mechanism of injury with subdural hematomas is often traumatic. Epidural. So epidural involves the middle meningeal artery, and subdural involves the bridging veins. Epidural hematoma I feel like epidural hematoma doesn't necessarily cause as much like brain shifting symptoms, although it is an arterial bleed, so potentially it would cause more severe symptoms as well. Especially epidural hematoma is associated with this kind of lucid interval. So for me, I'm probably going to go with epidural hematoma. So stroke is not going to, this is increased intracranial pressure, right? Cushing reflex. There's no reason for him to have subarachnoid, really. That's like more, you're thinking like Barry aneurysms and stuff. Subdural, I think much older patient, a rupture of the bridging veins. Epidural hematoma, he's a relatively younger patient and had a traumatic episode, had an lucid interval. So I'm going to go with epidural hematoma. Right, so this is all the things we talked about. Middle meningeal artery, lucid interval, brain begins to herniate, causing bradycardia, hypertension, and irregular respirations. For subdural hematoma, older patients and patients with alcohol use and blood thinners are at higher risk. Half of them become quickly comatose. The other half remain lucid for hours to days, slowly worsening into a coma. A 62-year-old woman is evaluated in the emergency department for chest pain. Contrast CT of the thorax is performed and stat lab results are shown. EKG, so I'm not seeing anything super obvious here to my eye. I'm just looking really like at the ST segments, looking for any ST changes. I don't see anything huge, and it's regular. Its rate looks like she's like about 100, almost a little bit faster than 100. And then her axis is right axis deviation, and intervals, QRS, PR, QT intervals all look normal. This is showing a CT scan, and then we've got this double lumen sign right here. You see this line right here? So she's got an aortic dissection. Creatinine normal, sodium normal, K normal. I don't know why they gave all these. And then D dimer elevated. So this is probably like to try and throw you off and be like, oh, this is like a PE or something. But this is a dissection. Definitely this patient needs esmolol. The reason esmolol is going to be the treatment of choice for this patient is it's a beta blocker. So it's going to rapidly lower the heart rate and it's going to lower the blood pressure, which is both, what you need to do for an acute aortic dissection, especially the heart rate. You want to get it to like 55 to 60. So she really needs to get that down. These other ones would not give you that same heart rate control that you would need for an acute dissection. All right, we're on a roll. A 57-year-old man presents for a routine checkup. There is a spiculated solid nodule and no lymphadenopathy. Which of the following is the most likely diagnosis? Bronchogenic carcinoma, pulmonary hamartoma, granulomatous inflammation due to histoplasmosis, reactivation of TB, and sarcoidosis. So bronchogenic carcinoma, I'm going to be looking for a history of cough, weight loss, and then smoking. Pulmonary hamartoma, I doubt it. This is going to be usually like tuberous sclerosis. It's like a pediatric kind of thing. So I maybe this could be in adults, but I feel like very unlikely. Granulomatous inflammation due to histo, I'd be thinking, East Coast exposure, potentially spelunking or cave activities. Reactivation of TB, you're going to find some kind of TB risk factor, and sarcoidosis would be bilateral hilar lymphadenopathy, hypercalcemia, things like that. So he reports no respiratory complaints or constitutional symptoms. He does have a 30-pack year smoking history and a history of treated pulmonary TB. He completed a full course of treatment for latent TB. So yeah, like I said, the smoking history is going to lead you to definitely bronchogenic carcinoma, and that is the correct answer. All right, let's do the last one, you guys. A 55-year-old woman presents to the emergency department complaining of an excruciating pain in her back that's been getting worse for the past month with concerns for urinary incontinence. So immediately, I'm thinking about some kind of malignant tumor causing cord compression, cauda equina syndrome, with this urinary incontinence. That's a little bit concerning. Although actually, a lot of times when people get involvement of the spinal cord, a lot of times we actually see urinary retention and bowel incontinence. But whenever you see some kind of like bowel problem in the history of like a worsening pain, especially a progressive subacute pain, that's making me think of some kind of malignancy. No tenderness along the palpation to the spine, but I just saw neurologic exam reveals mild weakness in both lower extremities and decreased sensation to light touch below the level of umbilicus. So definitely some kind of cauda equina syndrome coming on here. Which of the following is the most appropriate next step in evaluation? MRI spine, lumbar puncture, PET scan, CT scan, or bone scintigraphy. Without even reading the rest of the question, I know that the answer is MRI of the spine, but we can just go through the rest of the question just to make sure. So she reports the pain is located in her lower back and has gradually increased in intensity. She has a history of smoking 1 pack of cigarettes daily for 30 years, but quit 5 years ago, so a very high cancer risk factor. Her past medical history is significant for aggressive, advanced stage non-Hodgkin lymphoma, treated with chemo 3 years ago with poor follow-up for surveillance. Again, another very high risk for worsening malignancy, especially because she hasn't been following up. Denies fever, weight loss, changes in bowel or bladder habits, and she's just on amlodipine and atorvastatin, and her vitals look good. Definitely an MRI of the spine. Definitely needs to be evaluated emergently for possible cauda equina syndrome and given IV steroids to reduce edema around the spinal cord. All right, you guys, that's it for today. I hope you guys enjoyed going through these questions with me. Let me know down in the questions below if you'd like to see more of these board review sessions, and I hope you guys enjoyed. I'll see you in the next video, and peace.